So today's presentation is titled An Interprofessional Approach to Person and Family-Centered Care. And it's with great pleasure that I introduce you our speakers for today. So today we have Chloe Beskinski-Ferris. And so Chloe received her Bachelor's of Social Work from Ryerson University in June of 2018. And she's licensed to practice in the province of Ontario through the Ontario College of Social Workers and Social Service Workers. She has continued her education by enrolling in the Aging and Gerontology Certificate Program at the Cheng School of Continuing Education in 2021. And she's also taken the Gentle Persuasive Approaches, which is GPA, as well as Pisces. Chloe enjoys supporting older adults and is an advocate for interprofessional care, team collaboration, and communication. Her passion is supporting older adults living in long-term care. Currently, she's a social worker for Mackenzie Health Long-Term Care, and she supports residents on a daily basis with managerial responsibilities for a team of registered health professionals. Chloe is also a BPSO champion, as well as the co-chair for BPSO at Mackenzie Health Long-Term Care. She also works in collaboration with the team to ensure that the best practice guidelines are being met by all of the members of the team. I will now also introduce you to Erin Sibery. She is the admissions coordinator, and she's worked with the long-term care home for over the past 20 years. And she started out in a temporary role as a scheduling and payroll clerk at Mackenzie Health Long-Term Care. And then shortly after, the doors were open actually in 2000 as a 116-bed home. And so Erin became the office manager in 2003 and also took on the role of admissions. In 2009, Mackenzie Health Long-Term Care received a license to open a 32-bed interim unit, which Erin coordinated. And also in 2013 and 2019, the home received additional licensing to open up a 20-bed dialysis unit and 2 additional interim beds, respectively. So Erin played an integral role in the opening. So Erin continues to maintain an active connection with the residents throughout their stay in long-term care. And she's a liaison with the home and community placement. And in addition to pre-admission, admission responsibilities, Erin also manages the resident accommodation, billing and services, as well as the trust account. She maintains the home's accounts receivables and payables and is trained as a backup for payroll. And she's completed the long-term care administrator program in 2006 and has received her certificate in gentle persuasive approaches and is also a BPSO champion and active member of BPSO steering committee. She's also certified in health and safety and has served as a co-chair of the Health and Safety Committee since 2018. We also have Shariza. She also is the program manager of the home. And Sarija began developing her career in the geriatric field 5 years ago. And while completing her undergraduate degree, she worked as a part-time administrative assistant and in an independent living home, and was inspired to support residents during this transitional period of their lives. Shortly after graduating, Shariza became the life enrichment supervisor and enrolled in the Aging and Gerontology program at Cheng School of Continuing Education. Following her time at the independent living home, Shariza became the program's manager at Mackenzie Health. And in addition to this, she has received her certificate in gentle persuasive approaches, Pisces, and she's also a BPSO champion. So in collaboration with her interprofessional team, Shariza continues to assess, design, and implement programs to enrich the lives of the residents in the home. Last but not least, we have Clara Nissen, who's the Director of Care at Mackenzie Health. And Clara has received her registered nurse diploma from Kaplan School of Nursing, which is affiliated with the University in Tel Aviv in Israel in 1979. And her Bachelor of Science from Ryerson Palliative University in Toronto in 1998. In 2004, Clara received her Master's of Nursing with a focus on nursing administration from the University of Toronto. In 2014, she completed her primary healthcare nurse practitioner program at Ryerson University. Clara is very knowledgeable and a resourceful primary healthcare nurse practitioner with over 25 years of experience. She's also known for possessing a combination of strong clinical leadership, analytical skills, along with strong communication and networking that allows for troubleshooting and problem solving. She has demonstrated the ability to support residents and their families, nurses, interprofessional team members, managers, and she contributes to all team initiatives. She also has a strong organizational and project management skills for ensuring ongoing improvement of care. And she's been the Director of Care at Mackenzie Health Long-Term Care and the Best Practice Spotlight Organization Liaison since 2020. Again, it's with great pleasure that I introduce to you today our presenters.
So thank you very much for introducing ourselves, our amazing interprofessional team. And we will, my name is Clara Nisan. I'm Director of Care Clinical Services, nurse practitioner. Next slide, please. So a little introduction about our home. Mackenzie Health Long-Term Care is a 170-bed non-profit home in the Central Local Health Integration Network, LIN, located in Richmond Hill, Ontario. Our 170-bed home is comprised of 116 long-stay beds, 34 interim beds, and 20 hemodialysis beds. We are affiliated with the Mackenzie Hospital and managed by Universal Care Canada. Mackenzie Health Long-Term Care has benefited from strong and supportive leadership, resulting in innovative practices and thinking outside the box. We provide a formal palliative approach to care, aging in place, and we're one of the first long-term care facilities in Ontario to adopt the use of medical cannabis for chronic pain management, palliative care, and responsive behavior. Our journey with Best Practice Spotlight organization BPSO started in July 2020. Please. So here is our framework alignment, and we wanted to use it a little aspects for our objective. So as you can see, zero harm to patient, family, and the workforce. It's our main goals. And it's our core. So we will talk during our presentation with about patient and family experience, essential caregivers and family visit, psychosocial aspect of palliative care delivery in the home, person and family centered care, improved and measurement quality aims, robust process improvement, RNAO best practice spotlight organization, successful 2 years implementation of 5 BPG. Quality improvement plan in 2021-22 allies and goes together with BPGs. It's reduce avoidable ED transfers, and we will talk about this, and successful reduction in use of restraints. We will talk about transparency and accountability at all levels, staff education, continuous quality improvement, program auditing, goals of care, palliative care, pain management, IPAC and COVID, person and family centered care. Next slide, please. You can see that our steering committee and organizational chart is comprised from many interprofessional team members. Director of care, nurse practitioner, co-chair is our social worker, recreation manager, RIMDS coordinator, infection control, physiotherapist, quality manager, admission coordinator. We work on 5 BPGs, very successful, and implemented all of them. Assessment and management of pain, palliative approach to care in the last 12 months, end of life care during the last days and hours, person and family centered care, and alternative approach to the use of restraint. Each of those BPGs have a chair and have quality indicator champion with designated time once a month, full day paid to implement those projects with a strong collaboration with corporate team. Next, I would like to introduce Erin Sibiri, and she will continue this presentation.
Thank you, Clara. So at Mackenzie Health Long-Term Care, the opportunity for person and family-centered care approach begins prior to admission into our home. This being with our inquiry calls and our tours. So during our calls, we do gather specific information on the prospective resident in order to best answer to family and resident concerns. And for tours, our tours are personalized. They are in-person scheduled tours, and we do accommodate walk-in tours as much as possible. During those, we gather specific information in order to highlight areas and programs within the home that are aligned to the prospective residents' needs at the present time and how we can adapt as care needs change. We also promote aging in place. We recognize that these are prospective clients and starting to formulate a connection that can be beneficial should they choose to come to our home. As new homes are built and potential residents have more options for placement, we want to retain their interest in choosing our home. We have a very strong working partnership with our home and community placement facilitator. She has in-depth knowledge on our home, both the physical design and the layout, as well as our policies and procedures. She is able to answer specific questions and concerns that arise from families and potential residents. The bed offer process is conducted with compassion while still maintaining the legislative requirements for timing. Our placement facilitator is very familiar with the applicant and their situation, and she is able to ease the process for the resident and the families prior to them coming into the home. She also conducts a follow-up call within 6 weeks of the admission, and if there are any concerns that arise out of these calls, she does follow up with the team. However, since taking this very person and family-centered care approach, there have been very minimal, if any, issues that come up during those calls. Next slide, please. So pre-admissions were implemented in our home back in 2016. We had identified a gap in our admission process as a team, and our solution to this was to come up with the pre-admission meetings. It also helped to alleviate the burden of information sitting solely on one or two people. The process for facilitating these meetings, it's done with our placement facilitator as well as myself. We do coordinate those meetings with the families and residents prior to them coming in. The interprofessional team members that attend, we try to have as many as possible in attendance, that being our nurse practitioner, our social worker, our programs manager, our dietary manager, the unit charge nurse as much as possible, and myself, the admissions coordinator. And at those meetings, we discuss, we confirm, and we gather clinical, psychosocial, social, dietary information. We're able to identify potential triggers and risks. We discuss goals of care, aging in place, and our least restraint policy. We encourage all the residents and the families to bring forth any issues that they might have during the transition period and thereafter. And the benefits to these meetings are really multifaceted. It helps to ease the resident and family concerns. It familiarizes the resident and family with our care team in our home. It gathers the specific information that allows the team to begin the care planning process. And by addressing the administrative component of signing all of the consents and contracts, this allows the team, the resident and the family to focus on the physical and emotional aspects of the transition on the actual admission day. All of the information is gathered and the chart is prepared and given to our unit in advance of the resident coming in. Our admission package, which is quite extensive, is actually given to residents on a USB stick. It can be shared with other family members or friends that were not present at the meeting. So we give that to them at the time of the pre-admission. And in terms of personalizing the resident rooms, this of course is done specifically to that resident's preferences. It can be done prior to admission, on the day of admission, or any time throughout the course of the resident's stay. We also work very hard as a team to reunite couples into shared accommodation when possible. And now I'll turn the next slide over to Chloe, our social worker.
Thank you, Erin. As Erin mentioned, my name is Chloe and I'm the social worker here at Mackenzie Health Long-Term Care. So as the social worker, myself and our interprofessional team do advocate for person and family-centered care. We were doing this prior to having the official BPG guidelines, although they have really helped us to make sure that we're meeting all areas that we're able to. I facilitate the initial, special, and annual care conferences. So initial care conferences happen after 6 weeks post-admission. Special happens when there is a change in status, and annual happens annually thereafter. Empowering residents to be involved in their treatment decisions. This starts as soon as the resident comes into their home, and we maintain this the entire stay that they have with us. Supporting resident strengths, as well as identifying areas that extra support may be needed. Supporting system navigation for residents and their families. Oftentimes, families and residents do need support with external services such as optometry and dentistry. There are other outstanding services that they may need help navigating that system. Support with social isolation and loneliness. We do know what the outbreak and pandemic has done in long-term care just in regards to social isolation. So supporting residents and their families with any needs they may have. Supporting relationships between residents, families, and the interprofessional team. We always ensure that communication is very transparent and that residents and their families feel comfortable coming to anybody on the interprofessional team. Coordinating education that supports person and family-centered care. Some examples of this education include GPA, which is Gentle Persuasive Approach, pieces, and special education from our psychogeriatric resource consultant monthly. Some of these special educations that we've run in 2022 are caregiver burnout and self-care. We also do behavior rounds. This is a meeting that happens once a month between myself, our psychogeriatric resource consultant, and members from Ontario Shores and BSO have also been involved. These behavior rounds are a meeting where I get to bring up any responsive behaviors we're seeing in the home, and I do get strategies that I can share with the staff to help make that person more comfortable. Oftentimes we see very good success within a few days. So a psychosocial assessment. So a psychosocial assessment is a very important tool, especially when looking at person and family-centered care, as it helps us to capture the resident as a unique individual. The goal of the assessment is to capture information such as what support system does the resident have in place, who supports them, who is supporting them in the community, such as their family and friends, and who is now supporting them while they're in long-term care. Another goal of the assessment is to look at what the resident's life looked like prior to admission. What were their hobbies? What educational background may they have? What did they do for a living? And did they enjoy it? I run the psychosocial assessment by starting with meeting with the resident. I do try and capture all of the information I've presented in these questions with just the resident. However, I have in the past called families to provide extra information if needed. Goals of care. Goals of care is an assessment we use to capture the goals of care for a resident and their family. Having the goal of care discussion with residents and their families allows the team to best determine the best treatment plan. This goals of care discussion typically does happen by the initial care conference, although sometimes it does take a little bit longer as we do work with the family and resident to see what their goals will look like. Some examples of the goals we aim to capture in the assessment. What kind of life would the resident find acceptable or unacceptable? This is a direct question that we do ask, and oftentimes a resident will focus on CPR or no CPR and treatment options such as a G-tube. Another goal that we aim to capture in the assessment is the aspects of the resident's life that were important to them. For example, we want to know who that they feel close to, who do they want to be involved in their care, what do they enjoy, music, food, massages, what is their spiritual preferences, and how can we support them with that? And from here, we tailor our care plan to fit the specific needs of a resident. Resident and family satisfaction. So as a resident adjusts to their new life in long-term care, as well as our home, the interprofessional team works very hard to get to know the resident and their families. Myself, the social worker, does a psychosocial assessment with the resident and or their family if needed. As well, members of the interprofessional team touch base with the resident and family quite often in the first 6 weeks and then thereafter. As Erin had mentioned, our LIN coordinator does reach out to the family in that first 6 weeks, as well as myself. I do touch base with the family members before that initial care conference to make sure that we're able to capture any questions or concerns they may have. As well, Erin, our admissions coordinator, also does check-in calls. Residents are encouraged throughout their stay to bring forward any concerns, ideas, or suggestions to the team. So we do check in mostly in the first 6 weeks. And then after that, we do help to facilitate relationships where the residents and families are able to bring any concerns forward and any suggestions. Care conferences are held at 6 weeks. These are our initial care conferences. By this time, the team knows the resident and family well. This allows the team to accurately report on how the resident is doing and what their needs are going forward. So that initial care conference, we do have multiple disciplines come to the meeting, and residents and families do ask very specific questions that are very often very specific to their care. We ensure that there's effective communication between the resident, family, and the care team. I will now pass it back to Erin for measuring outcomes.
So a few ways that we're able to measure outcomes. We do surveys annually. This is conducted with the family members and with the residents directly. We keep a compliments binder of any positive emails or cards that have come through. We do share these with the staff, and we do keep them in-house. We've seen an increase in word of mouth referrals coming in. We have had a decrease in complaints and concerns. And we do have a number of residents who have chosen to stay in our home even after their first choice for placement is offered to them. As mentioned before, we do provide appropriate follow-up on any concerns with the appropriate team member. We do make ourselves available to the residents and families and the staff throughout the day on the units, or always by phone or by email. We follow up after a resident is discharged. Many members of the interdisciplinary team will reach out to families after a death to offer condolences and support. Our social worker calls families, and if available, will ask the questions about quality of care surrounding the 8 domains of the BPSO. Our home, we do a code butterfly after a resident passes, whereby the team will gather to honor the resident and say goodbye as they exit the home. After that, we will do a huddle with the nurse practitioner and the social worker to talk about the resident's stay with us. We have increased our staff knowledge and coaching through the leadership of the nurse practitioner, which has resulted in a 45% decrease in transfers to the emergency department in 2015, and the trend continues with an annual average of a decrease of 31% in transfers to the emergency room. Our registered staff are given the knowledge and tools to assess and evaluate resident outcomes, resulting in a 40% decrease in residents with pain and a decrease of 48% in antipsychotic drug use without a diagnosis. We believe that the interprofessional and holistic approach to any change in practice has really allowed us to weather many challenges and storms that have come our way. Next slide, please. So our nurse practitioner and social worker really pioneered our palliative care program, adopting a person and family-centered care approach back in 2015 and 2016. Both the residents and the families have responded positively to our palliative care approaches. The promotion of aging in place and improved quality of care has resulted in reduced emergency department transfers, as mentioned before. This has been freeing up hospital beds, and residents are more comfortable now that they have better pain and symptom management, and they're able to remain in familiar surroundings with familiar staff and their family. Staff is more knowledgeable and feels more confident in providing end-of-life care. Residents and families feel more satisfied with the care provided after being part of the care planning process. Our palliative care residents and their families are receiving the right care at the right time by the right providers. And although the loss of any resident is difficult for us all, we know that we're doing our best and we can allow our residents to die with dignity and to honor the lives they lived. And having been here the longest out of the interdisciplinary team, I can truly attest to the impact that taking a person and family-centered care approach has had on the home. With dedication and persistence and lots of teamwork, we've been able to make this approach part of the fabric of how we operate. And with that being said, I am going to turn it over to Shariza to speak from the standpoint of recreation.
Hi, good afternoon, everyone. My name is Shariza, and as Erin said, I'm the programs manager at Mackenzie Health Long-Term Care. So what is the purpose of recreation therapy? At the core, recreation therapy is a systematic process that utilizes recreation and other activity-based interventions to improve or maintain the physical, cognitive, social, emotional, and spiritual well-being of a resident. This process helps to maximize a resident's independence and improve their quality of life. So what exactly does this process entail? The recreation therapist must begin this process by developing a meaningful relationship with the resident and their family, in which they determine the best way to assess current interests, abilities, needs, and barriers related to a meaningful leisure lifestyle. The assessment is one of the key elements of recreational therapy practice. Recreational therapists are trained in the assessment of physical, social, cognitive, emotional, and spiritual well-being of a resident, which is fundamental in identifying the needs, interests, preferences, and life routines of the resident. Based off of this assessment, they develop a care plan that supports the resident's strengths and needs, including modifications and adaptations to provide success for the resident. The recreational therapist utilizes various facilitation techniques to engage the resident in a variety of opportunities and chooses reliable and valid measures to guide the care plan and evaluate the resident to ensure a meaningful leisure lifestyle. So how do we document and why is this important? The unique feature of recreational therapy that makes it different from other therapies is the use of recreational modalities and the designed intervention strategies. Recreational therapy is extremely individualized to each person by his or her past, present, and future interests and lifestyles. Care plans are reviewed and adjusted quarterly to address the increasing complex needs of all residents to ensure that we are able to meet the residents' and families' custom goals and implement the appropriate interventions if necessary. In addition to this, we use POC's platform to track and categorize which programs the resident attends and helps us to identify any changes that may develop over time. Through documentation, we are able to continually assess our residents so that their progress or lack of can be effectively measured. Next slide, please. So how do we personalize programming? Our approach is all about the resident, their needs, and their passions. Ultimately, we're trying to get to the core of this resident. What brings them joy, and how can we help them attain it? It is during the initial assessment, care conferences, and continual conversations with the resident and their families that we continue to learn and better understand how to personalize their programs. It's all about inclusion and empowering the resident to live their fullest life despite limitations. This means breaking barriers. We do this by modifying and making the necessary adjustments to a program so that every resident is able to participate. Recreation therapy seeks to give as much power and agency as possible to a resident by offering a variety of choices that speak to their physical, cognitive, social, emotional, and spiritual well-being. We want our programs to be purposeful and designed to match specific interventions for each resident. Whether a resident and their family wants to improve coordination or continue to engage in art-based therapies, we help residents and their families achieve meaningful goals with specific outcomes. Ultimately, our end goal is to enable all residents to achieve quality of life and optimal health through meaningful participation in recreation and leisure, and to inspire joy on a day-to-day basis. I will now pass the slide to Clara.
Registered staff in interprofessional team education. With an aim to improve quality of resident care, including quality indicator, as an NPDOC, I plan to provide annual mandatory professional skills days for all registered staff. The goal was to ensure all nurses had access to continuous education on best practices to improve critical thinking, knowledge, judgment, and skills. I firmly believe in the importance of providing the right care at the right time by the right provider. With our aging population, an increase in chronic disease, and physicians shortage, our interprofessional team contends that there is an urgent need to respond to the changing need of Canadians. More directly, with improved access to services, resources can be utilized more effectively, resulting in increased satisfaction in the resident and their family. Practice change that was implemented in our home. 2 days professional skill training were provided annually for registered staff and interprofessional team member by internal and external experts that support the training. This included RNAO, long-term care best practice coordinator. At the present, we have a total of 50 quality champions from BPSO in our home. The quality champions are interprofessional team members. Next slide, please. Our interprofessional team continues to support residents and their families in strong collaboration with the residents, their families, hospital, corporate team, and decision support staff. As a nurse practitioner DOC, I am a lead for BPSO, consistently showing leadership with interprofessional team using holistic approach. This is evident in medical-based areas as well as psychosocial initiatives, such as our palliative care program, pain management, decreasing antipsychotic medication, use without appropriate diagnosis, as well as conflict resolution and patient-centered care. Interprofessional team is providing high professional standards, empathy, and commitment to improve health outcome for frail and vulnerable population with many comorbidities. The team successfully intervened and was invaluable in resolving many complex clinical and ethical residents and family situations during many special conferences. Next slide. Ongoing planned improvement initiative, RNAO best practice spotlight organization, updating progress with PPG, person and family centered care, embracing changes, improving resident quality of life, and meet new Fixed Long-Term Care Act 2021 legislative requirements by implementing person and family centered care RNAO best practice. All our patients, residents have My Care plan and its resident-centered approach. Pre-admission conference and checklist collecting residents' information for better transition to the home and quality care services. Home specifics, patient family centered care gap analysis completed, action plan created, full implementation is expected by June 2022. Next slide. This is just one example of our knowledge dissemination to all staff, to all residents during a resident council or a family council. We also provided the information and posters on every floor of our home as well to corporate group and to the hospital. So we are trying to disseminate our knowledge to see what's our journey to BPSO since 2020. We have visual graphs to show our success story, especially, for example, worsening pain. You can see that here we are much below provincial average, as well as use of antipsychotic medication and all the brochures that we are giving to our residents and their families. Thank you. And if you have any question, please let us know.
Thank you so much to all of you for taking the time to present this information to us. It was really a brilliant and very engaging presentation, so thank you so much. I know that one of the things that stood out for me in your presentation today is in respect to the framework that you spoke about, the framework alignment that you showed us. And it was great to see the connection between the different aspects of the work that you and your team are doing, from palliative care to the assessment and management of pain, and even person-family centered care. So it was really great to see all those aspects pulling together. And I really loved how the organization embodies a holistic approach, paying a great deal of attention to the processes in terms of pre-admission, conducting a psychosocial assessment, goals of care, and also your recreational therapy program. So at this time, I would like to give the audience a chance to ask some questions. I do see some questions in the chat. And so I'll take a moment to have a look at those questions and see if we can address some of those. So there is a question here from Lydia. So Lydia states that she's an agency nurse and she's noticed that patients are waiting quite a while to be placed in long-term care homes for months and even years, and sometimes are even declined admission due to their behavior. And she's wondering, what do you provide in respect to that? And what do you do when you have patients with language barriers?
So it's Erin. So I'll address as much of that question as I can. So we are seeing a change in the residents coming in. That's why having a palliative care program in place has been really invaluable for us. We are seeing a lot of residents coming already almost in the end stages. So that has been a change. They are waiting longer in the community to come in. They are waiting in hospitals or reactivation care centers. So having this approach already embedded in what we do has helped us sort of weather the changes of the changing population for sure. The other half of the question, I'm sorry, if you could repeat that other half.
Sure. Yeah. So she was asking about language barriers, like how do you address things like that when you have residents that come in with language barriers? And just in general, any behavioral issues that may arise, how do you address that within the home?
So both language barriers, we do look to the family for support and also to our own staff to look to see if we have any staff in-house that can help with that. I can let Chloe and Shariza also address the language barrier. I know we've done communication cards and things like that. In terms of responsive behaviors, I will ask Chloe to speak on that because we do involve the LOFT program, Behavior Supports Ontario.
Thank you, Erin. Sorry, could you kindly repeat the responsive behaviors question for me and I will address it the best I can.
No problem. So I think it's just they're wanting to know a little bit, how do you deal with maybe a resident that is coming into the home that maybe have behavioral issues? How do you address that from the home's perspective? Because they've seen some homes decline residents based on any behavioral problems or issues.
Absolutely, I can speak to that. So if a resident comes into our home and we do note responsive behaviors, we start with something called a DOS, which is a monitoring data system, and that is done by the frontline staff. Once I have the DOS, which is about 7 days of data that I do ask to be collected, I do one of two things. So the first thing I'll do is I'll reach out to my PRC, which is the Psychogeriatric Resource Consultant, or the BSO team, which is Behavior Supports Ontario, for a round. This does already happen scheduled once a month, but if there is an emergency, they will also meet with me before then. And we look at reasons as to why the behavior may be being displayed. So one of the most recent examples I can think of is somebody was showing a lot of agitation, and it actually turned out that her dentures were uncomfortable, and they had been since pre-admission due to COVID not being able to get to a doctor. Other things are residents are confused as to where they are, so helping to orient them, just different underlying factors. The other thing I'll do is I will do a referral to BSO, which is Behavior Supports Team. They also go by BSS, which is Behavior Supports Mobile Team, I believe it is. And they can come in and help us staff in the home. They do a pieces presentation for us, which does allow us to see what the resident's life looked like prior. So there may be things that we're not addressing. Sometimes it's a resident has lost a spouse or a family member. And so they do bring up those things for us to help identify those areas of need. So together with the BSO team, when they're involved, we do typically see a lot of reduction in the behavior. In regards to language barriers, which I'll touch on as well while I'm here, Erin did mention we do use communication cards. Other times, if I'm doing a psychosocial assessment or I am trying to figure out why a resident is maybe having responsive behavior and where there is that language barrier there, I'll look for a staff member in the home that does speak that person's language. Otherwise, I'll communicate with the family and do maybe a phone call between myself and the family and the resident at present so that there can be translation. And oftentimes we are able to figure out what that underlying cause is. So if it's pain, then I would talk to Clara and let her know what's going on there. And if it's something else that we can change, we do it. So sometimes it's timing of access to care. So they want an updated care plan, or it's they're feeling isolated. So we try and connect them with other residents that speak the same language or maybe have similar interests.
Thank you so much, Chloe. Just to being mindful of time, and we do have a few more questions that I want to touch on. So there's a question here from Lincoln asking about, what are some of the barriers faced within the interprofessional team in terms of achieving the high level of quality care that your team is striving for? Were there any barriers that you encountered?
So it's Clara. Our team, we are very lucky to have such a young and enthusiastic teams who wants to do the best for our residents. They love geriatric population, all of them, one by one, people who are working here, they love the geriatric population. So this was our really privilege to work with all of those team members who are so interested to do better and to think outside the box. In 2015, also we started to integrate cannabis use in our facility, and it was initiated by RNAO webinars that we heard first, and then we started to work on it to help to our residents with behavioral and responsive behavior as well as pain. So it helped us a lot, and still to decrease antipsychotic use. So this was, we didn't have any problem with our interprofessional team, such as speech language pathology, dietitians. We have an amazing team members, as well as physicians. So, and all of this was supported by our corporate team, because for using cannabis, we needed policy, the procedure, everything was done on time, and we could have started very nicely this project.
Awesome, thank you so much. I'll just pull one more question because of time. So does the support start in hospital setting where patients might be coming from, or does this support only is initialized in the long-term care home on admission? Someone was wanting to know a little bit about that.
I can't speak directly, it's Erin. I can't speak directly to what happens in the hospital setting, but what I can speak to is our LIN placement coordinator. So our home and community placement coordinator, who has the first connection to the residents prior to them coming into the home. She is extremely supportive. She knows the application well. She knows where the person is. She's spoken to the family. She's aware of any family dynamics that might be happening. So she is supporting them prior to them coming to us for pre-admission. But in terms of actual support within the hospital, I'm guessing that there is, however, I can't speak to that directly.
Awesome. Thank you so much, Erin. And it was really a pleasure hosting you today, and to really hear from you and hear what your team are doing. And we really enjoyed the presentation. You can tell by the engagement on the chat. We didn't get to address some of the questions, but if you're curious to learn more about what Mackenzie Health Long-Term Care is doing, you can definitely reach out to us and we can connect you with the team to further answer the questions that we weren't able to address today. So we really thank you for your participation in this live webinar. You will soon receive a link to an online survey to evaluate today's presentation. And after you've done the evaluation, you'll receive your certificate of attendance. attendance. In addition, we wanted to let you know if you have any suggestions about future topics that we can speak about, please let us know. And lastly, just to let you know that this work is funded by the Government of Ontario. And we want to thank the presenters who are on the call today. Thank you so much for your time and for the details that you've provided about the work that you're doing. Thank you everyone for spending the time with us today, and I hope you have a great afternoon.